My presentation today is about using machine learning methods to enhance BBV and STI surveillance among people who have injected drugs. I'd like to acknowledge my colleagues and co-authors who are listed here, and I'd also like to acknowledge people with lived and living experience of injecting drug use and the importance of centring that experience to best understand and interpret our surveillance and research data. Public health surveillance is the ongoing data collection, analysis and reporting of relevant health information to inform public health action. The more detail we have in our surveillance data, the more we can understand the characteristics of the people who are most affected, and that gives us the opportunity to then design interventions that match to those characteristics to reach more people in a more equitable way. There are many different sources of data that have been used for surveillance, and a really powerful source is medical records that are extracted directly from clinical practices because they represent real-world interaction with clinical services, and the routine nature of the data means that we can measure burden of disease over time and evaluate testing and treatment uptake to provide measures of cascades of care. In Australia, we have a sentinel surveillance system called Access that extracts clinical data or electronic medical records from over 100 sentinel clinics around the country. It uses a privacy-preserving technology called Burnet to interface with different patient databases to extract that data securely. The clinics that are participating in Access are clinics that conduct high rates of testing and treatment relative to their location. And so they tend to represent the populations that need BBV STI services the most. In Australia, people who inject drugs are the primary population burdened by hepatitis C and a priority population for elimination of viral hepatitis and HIV. So we need to be able to find indicators of injecting drug use within our data to be able to group people with IDU history for surveillance analysis. It's important to note that even if IDU is disclosed at the clinic, IDU behaviours are often documented in free text in the patient notes, and Access isn't able to, they're not available for access due to privacy and confidentiality concerns. But there are some indicators of IDU that exist in Access. So self-reported injecting drug use is collected at most of the sexual health clinics via a behavioural survey as part of routine care. And Access has that data available, but that's only in less than half of the clinics. In rare occasions, IDU has been recorded by providers as a reason for tests in about 0.1% of records. And opioid agonist treatment prescriptions have been used as a proxy of injecting drug use, but of course they exclude people who've not injected opioids. So relying on just these three indicators can produce a biased subsample of people who've injected drugs in Access, and there are likely people who remain unrepresented in the data. So how do we find these people when Access contains over 16 million consultation records and over 100 variables from various clinic types with different clinical practices and patients with different needs? This challenge of trying to find new indicators in such complex data requires automated data-driven approaches to be able to make sense of all the data, including the missing information. So this led me to investigate machine learning. Machine learning has the capacity to automatically analyse large volumes of complicated data to find patterns that exist between variables among all of the records that are available. And often these are, and this is statistically done, these relationships that are found between all the variables are not obvious to human experts usually, and they're difficult to discover usually using traditional biostatistical methods. Machine learning algorithms are trained on a subset of observed data to subsequently make decisions on new data based on the patterns that it's learned. So we can provide the computer with a sample of examples that we want it to learn from, and then it'll come up with its own rules without the need to program, so it's completely automated. So the aim of this research was to evaluate whether we can implement machine learning to identify injecting drug use in the absence of known indicators. So I've just included this diagram to show how iterative and, I suppose, resource-intensive and time-consuming machine learning can be. So from development to deployment, there are so many steps involved. To train and test it, we've all heard a lot about the development of models and the internal validation, but very rarely do we hear about the application of the model and how we evaluate that. And particularly in a data set where we have some indicators of injecting drug use, but in the majority of the data, the IDU status is missing. So we are currently at step 2. Oops. Go forward. Wrong one. Okay, so we are here now. So we've developed the model and we've now applied it to all of the Access electronic medical records, and we need to evaluate the model output given that we have so much unknown. And so the iteration is then you tweak it, retrain, reapply, and so on and so on. And once we're happy with that, we can then integrate the model into Access data processes, and of course there's a whole lot of QA that goes on there before we're able to use it live. So a little bit about how the model was developed. So we used 2,422 people who had evidence of IDU, as I described before, and an equal number of other people where IDU was unknown. So then I was able to use 88 variables compared to the just 3. And this here is just a sample of some of the data that was prepared for the examples given to the model. The model then analyses the combination of all the variables, or the values for each person, compares them to those of the people known to have a history of IDU, and then generates a probability between 0 and 1. And the closer to 1, the more likely the person is to have had a history of injecting drug use. The model performed well on internal evaluation with a sensitivity and positive predictive value of 93%. So when we have a majority of unknown IDU status and millions of records, we need a way to manage the possible misclassification. And risk stratification is a method that can be used to do that. So with risk stratification, it's often used in clinical decision making where clinicians can systematically grade someone's health based on a threshold value and recommend next steps. So similarly, we grouped patients into, or people into different categories based on their estimated probability levels. So we grouped people into high probability group if their probability was greater than 0.75, and a moderate probability group if their probability was greater or equal to 0.53. And then we examine their characteristics to evaluate the feasibility of the method. But I'm just going to present a couple of results for the high probability group. So the Access database has medical records for 1.7 million people over a 20-year period. And using the 3 initial variables, we can find 50,236 people who've either had a self-report or provider-indicated IDU. So it's about 2.9% of the total cohort. And then when we apply the model, counting only those with a 0.75 threshold, an additional 45,495 people were located that are highly likely to have injected drugs. So in terms of what this can do for surveillance, it can potentially give us a more accurate number. And if we characterise these people together, it can provide a more comprehensive understanding of the reach of healthcare and harm reduction services to people who've injected drugs. This slide shows the distribution of clinic type. On the left is people who self-reported, people with provider-indicated IDU, and on the right are the people who were classified with the 0.75 threshold. So you can see among the sexual health clinic, this is where most people will self-report, not many more people were found. So that sort of gives us an idea that this is capturing IDU pretty well. And where we were underrepresenting people, or potentially underrepresenting people with a history of injecting drugs, is among these other clinic types. And what gives us confidence is that the clinic types that provide drug and alcohol services have a really high number of people predicted to have a history of injecting drugs. So this slide shows the distribution by age and sex. And again, on the left is the people who self-report, people who have provider indicated. On the top is male at birth, and on the bottom is female at birth. And on the right is the additional people captured by the model. And the number of male and female, even though on this side, if we just use the indicators that we knew, the number of female birth is much lower, but the model has found a very similar number of male and female. And the stark difference, I guess, or the obvious difference, is this change in the age distribution of the women that we would otherwise not have seen. So for this group, we can now further investigate the characteristics and the health service uptake so we can better inform and customise services and include them in our reporting. So using machine learning and risk stratification means that we can potentially improve the visibility of certain groups and uncover characteristics that were being missed that are important for planning and resourcing. So surveillance using clinical data can miss important groups by relying only on the direct indicators that we know of. Machine learning can explore data in an automated way, in a way that I guess we couldn't just because of the complexities of healthcare data, and identify new indicators of IDU, even if they are combinations of large numbers of variables. 100% certainty is not possible, so risk stratification is a useful tool that we can use to manage misclassification and increase our confidence in the group that we capture. Machine learning has the potential to improve the representativeness of important characteristics, these methods I should say, but it does require very careful iterative evaluation to ensure that it's robust and fair and fit for purpose. I'd just like to acknowledge everybody who's involved in access, including the patients. This was part of my PhD, so I'd like to acknowledge my supervisors and the financial support. Thank you.
Yeah, thank you so much, Carol. And I just want to know whether from the audience we have any questions. We are giving an option for just one question for the interest of time.
Right in the front, yeah.
Hi. It's here.
Thank you for the great talk. I was just wondering about your model. So the classes that you had were known, people who were known to inject drugs, then people with unknown injecting. So what type of model were you using? Was it a semi-supervised model, or could you give some more details on the architecture?
Yeah, sure. It was a supervised model and with a balanced data set, and it was an iterative person-in-the-loop situation. So every time we train the model, those zeros were the unknowns. We would do an error analysis or a data audit And then where we found additional evidence of IDU, we would then change them to a positive and then continue like that.
Okay, so from the beginning, you never had a class that was no injecting drug
That's
use?
right.
Okay, gotcha.
Yeah.
Well done, thank you.
Great. All right. Thank you, Dr. El-Hayek.
Thank
We'll
you.
move on to the next for the sake of time.